Good afternoon. That's a tough act to follow. It's a $2 billion massive, super impressive space. I'm going to now talk to you about what we've done out of 620 square feet in the oldest Catholic hospital in Phoenix. So my name is Dr. Solon. I am a trauma surgeon and surgical intensivist by trade, still clinically in active practice, and really honored here to share with you a little bit of the work we've done on what's now called the Knowledge Donor Program. We're based out of Dignity Health, St. Joseph's Hospital, now also Common Spirit by corporate affiliation. This is a program that's been in genesis for about 5 to 7 years at our institution, and I think as it's matured, we've really sort of coned down to a couple of major problems in healthcare that we're addressing. Really, I'll talk for the first half of this talk around that middle vertical, talking about education, and then more recently really understanding how our platform has become an accelerator for innovation and maybe an opportunity for collaboration with many other healthcare startups and other companies of various maturities as they get their innovative products to the bedside and past FDA approval. But our program is founded on two uncomfortable fundamental truths in healthcare that go unspoken to the general public. The first is that no matter how well trained, how well studied, how well, quote unquote, prepared, everyone has that first time holding a scalpel, holding an intubation blade, holding a patient's life in their hands. This is a photograph from pre-vaccine COVID in the early phases where we really didn't understand the course of this disease. And if you worked in a healthcare system, a lot of the protocols coming up were talking about how the most experienced airway practitioners needed to be handling these rapidly decompensating patients. And here in the national press was a photograph that struck us because I think we've all had that look in our eyes at one point or another, and we've all seen that look in our learners. And if you had to guess the level of learner here, I can tell you it's not the anesthesiologist with 20 years under his belt. This was an ER MD who'd been an MD for all of 5 months at the moment that this photograph was taken. So that's the first truth about our profession in healthcare and more specifically in surgery. The second truth is we call it the practice of medicine. We call it the practice of surgery. You open up a surgical practice. We are the only high reliability profession that practices and performs on the same platform. That platform happens to be someone's mother, someone's brother, someone's daughter, someone's son. And I'm also the clinical simulation director for Creighton School of Medicine in Phoenix, and we're bridging the gap with this, right? And the sweatshirt is not selling the story that this is anything close to a living, breathing human being. And the metaphors are unlimited for other high reliability, high stakes, high performance professions that you would never give an NBA player a 3-foot basketball hoop and expect them to hit a game-winning jumper in the fourth quarter. Right? Our airline pilots are not practicing on simulation materials that look like Fisher-Price toys and then landing with one engine in the Hudson River. So in 2026, this is what is considered high fidelity in medical simulation. This is a $100,000 cut suit. You can strap it onto a live patient actor and simulate all sorts of high acuity, low occurrence, invasive medical and surgical procedures. If you actually work in healthcare on real patients, this is a completely insufficient model. This looks like the Barbie dolls from our youth. This looks like maybe from last year's Ryan Gosling movie. But every July, we send our learners into the real world, and the real world looks nothing like our simulation environments in our trauma bays, in our emergency department wards, in our intensive care units. And I think as medical education is headed in the opposite direction of fidelity, let's make it virtual. Let's have the American Heart Association teach how to treat a patient in cardiopulmonary arrest on a cell phone or a tablet. If you've ever been in the real world with a real patient in real life, you understand how broad and broadening that gap can be. So we have a problem in medicine and healthcare in that everyone expects the general public to look at an MD with a stethoscope around their neck and a pair of scrubs on July 1 and expect that we're this out of the box of training. And we all know the reality is very different from that. I think there's an unspoken crisis in the modern healthcare education environment that we have to learn more in less time, and we have to do it with more pressures on the electronic healthcare record, more clerical tasks, less autonomy. And so the results are unsurprising that in my profession, 85% of the surgical residents coming out of 5 years of training want to pursue more training, and that 2/3 of them are felt unable to perform basic operative procedures unsupervised after this training. This is not just a surgery problem. This is 1 in 5, or on a 5-point scale, this is 274 internal medicine residents self-rating their own confidence on basic bedside ultrasound-based and other procedures. On a 5-point scale, that's about a 1.7. I don't get into an Uber without anything less than a 4.9. Why are we trusting our learners to perform procedures on our loved ones? And the nursing shortage, part of Arizona, part of the national conversation, of course, a massive challenge that not only do we have to train and produce more healthcare workers into our workforce, but we have to keep them. And the idea that we're going to lose 1 in 3 nursing grads after 12 months, after investing so much into their education, really just highlights how difficult it is to dig ourselves out of the healthcare workforce hole that we're in to fill the needs of the next generation. So 4 founders, myself included, decided to do something about this, incubating inside of a large healthcare system. And from an education standpoint, cadaveric-based training has always been the gold standard of how we practice procedures and operations and learn anatomy in our field. There's a lot of barriers to scaling that. It smells terrible. The degradation rate is really high, specialized infrastructure and cost, and the ethics are gray for tissue acquisition. But more recently, more technology has modernized and given us the opportunity to modernize this platform, scale it, and apply it to the education of our surgery and medicine students and residents. Ethics was a really important part of this paradigm. We're with a Jesuit academic university partner in Creighton, and we're with the oldest Catholic healthcare system in Phoenix. It took several years of discernment that everything we were doing on whole body donation donors was done ethically, thoughtfully, with a safety first process at the forefront of everything we do. And so we took these building blocks and we built a scalable human simulation platform, and we put it in a simulation environment that we feel is unrivaled in this space. And in terms of what this can look like, this is one of our research residents who wanted to go into cardiothoracic surgery, building his own pulsatile ventilated bleeding model to practice putting a patient on heart and lung bypass, no risk to patient safety. Looks better in video, but lots of slides here in full resolution. We found that the simulation environment was critical, that if it looked, felt, and sounded like an anatomy cadaveric dissection lab, the learners would treat it as such. If we made it look, feel, and sound like a living, breathing operating room or intensive care unit, the learners would treat it as such. And so small details in terms of the acoustic environment, the visual environment, the tactile environment complemented the exceptional tissue quality that came off of our preservation technology that underwrites the tissue on this platform. So we realized that this was a fundamental paradigm shift in how healthcare education could be delivered for any provider conducting procedures on real patients. And what I mean by that is that if you go to a hospital, the exposure is fundamentally unclustered. Whatever comes in the hospital that day is what you get to learn on. So in proof of concept, we took a procedure called the chest tube, of which 1 million of these are placed in this country annually with a 7 to 40% complication rate. And in one afternoon, we gave unlimited, repetitive, clustered opportunities for medical students who would never be allowed to do this in real life, to do this on our platform. And what we found was that after one afternoon of training, they were beating the pants off of our surgical interns, and they were performing this high acuity life-saving procedure at the speed and competency of 2nd and 3rd year surgical residents that had had 24 to 36 months of additional clinical exposure. We brought this to our residency. We brought this broadly across our medical school at Creighton, and now 140 chest tubes later, we're finding a very consistent data-driven story that repetitive clustered training makes proceduralists and surgeons better, faster, sooner, and safer. So we learned a few lessons along the way as we scaled this in proof of concept that complexity was unlimited. We could have everything from a complex vascular surgery to a cardiothoracic transplantation team practice in high fidelity on our platform, that medical students, nursing students, fellows, surgical residents in any specialty that was procedural could benefit from training on this platform, that interprofessional activity benefited from augmentation in ultra high fidelity. And finally, that the surgical environment is a very privileged environment. Not very few people get to be in a living, breathing operating room. We could democratize the insights that surgeons enjoy to non-surgical providers. You recognize from the baseball hats, this is our Phoenix Fire paramedic providers that have to do a very similar emergent procedure to a chest tube in a moving ambulance with a 45% success rate. We put surgical cameras into the chest. We had them make their best attempted guess based on the anatomy, and then we turn the screen around. We show them the other side of the skin where the needle landed, and they could figure out why their angle was better, best, or not so great. So scale was important, and as we crossed a 120 student a year medical school at Creighton and a 52 resident residency, we realized if we did not scale right off the bat and provide a broad base of opportunities to our learners, that we wouldn't really achieve our goals. And so, to be honest, out of a studio apartment-sized room in Boston in our simulation center, 620 square feet, we've hit 5,400 learner touch points coming across our program over the last 18 months. And that's about 1 in 6 to 1 in 5 approaching of pretty much all medical students in the the city of Phoenix, and all GME or surgical and procedural residents in the state of Arizona and our city. So to give you a visual of what this looks like relative to the status quo, this is what a traditional formaldehyde preserved donor looks like in any anatomy lab in any medical school in this country. And if you look at the jump between that and a living, breathing human being, this is a case report of a forearm emergency surgery on a patient. This is what our donor platform looks like on a donor that's been decedent for 10 to 14 days. This is a scalable, multi-use use of the anatomic donor, which has never been possible in fresh tissue applications. So that's the education side. Now, why am I telling you all of this from a group of folks that are in the medtech and biotech spaces? We also recently discovered how impactful this tissue platform, this ability to simulate physiology, to have ventilation modeling, to have bleeding modeling, had for medtech development. And so the idea that, I'll skip through some of this in the interest of time, this could be a super magnet for industry collaboration was a lesson that we learned in ad hoc relationships over the last 2 years. What does that mean? It means some of the largest companies that are not resource constrained, Neuralink was one of them, were having trouble solving technical problems in the course of their product device development that required exceptional high-fidelity tissue. Barrow Neurologic Institute down the road was in competition with UCSF, with Stanford for the first brain chip clinical trial site. We were tip of the spear for innovation. This is not a living, breathing patient. This is one of our donors, and this is what the brain tissue and the vasculature can look like. And so when you're trying to figure out how to implant 1,024 fine needle wires into the brain without hitting a blood vessel, you need high tissue fidelity to do that. This is a surgical shot of the deep space of the inside of the brain in full fidelity. This is tissue you will not see anywhere else in the world due to how difficult it is to preserve and the pipeline of fresh tissue, ethically sourced, required to preserve this type of tissue quality. Always a patient story at the end of every innovation. This is our first patient at the Barrow who received a brain chip interface implantation. The spinal cord injured patient now improving his quality of life by being able to control a computer system with only his brain and a Bluetooth chip sitting under his skull. Other companies coming across our airspace also have transformative technology. This is Histosonics. They're a mature company, 13 years in the making, spun off from the University of Michigan. Series C overfunded by Johnson & Johnson Innovation. We saw their tech and we said if even 1/2 of what they're proposing is true, they're going to transform massive swaths of surgical oncology. They've created a non-invasive way to treat surgically unresectable tumors around blood vessels. So their engineering teams were collaborating in our space and learning all sorts of lessons, testing and training and iterating in high fidelity. Finally, we have all sorts of engineering innovations. We've had ASU biomedical engineering students in our platform. We've had other research fellows from other institutions collaborating with our surgical teams. We've got a wonderful complex hernia group at our hospital. And one of the novelties of being able to teach and practice and iterate on devices such as meshes to treat hernias is that if your whole body donor doesn't have a hernia, well, you can't practice treating one. So we made a hernia, and we made all sorts of complex hernias in different anatomic spaces. Rare hernias, difficult to treat or fix hernias, and now we have a platform not only for education, but also for device companies who have mesh fixation technologies and other technologies that they want to trial, iterate, and implement without practicing on living, breathing human beings. I'd be remiss if I didn't talk a little bit about where AI was headed in all of this and where data was headed in all of this conversation. In my space, in my field as a surgical medical educator, it is unknown, believe it or not, what makes a good, better, or best operative performance. This is a data gap that remains largely unquantified in our space. And so as we measure more learners, as we measure the progression of more medical students and surgical residents, how do we define how quickly they're progressing? How do we define when they're ready? We have to bring video, we have to bring strong data and objective metrics to that conversation. So we're very proud to be collaborating with some of the augmented intelligence teams at ASU and collecting more data to analyze, to understand what are the factors that are going to impact a better surgical performance for our patients. So these are the building blocks of modernizing a gold standard, of building an ethically sourced whole body donor acquisition pipeline, of leveraging novel and revolutionary preservation technology, and building a simulation platform that serves not only the educational needs of our students and learners, but also the innovation needs of companies that want to accelerate their ideation of a benchtop device to proof of concept or iterate on a device already in development towards an FDA approval. So we feel this is disruptive for healthcare education pedagogy and also a massive accelerant for rapid cycle translational research and innovation. So a growing number of partners. We wish we had more space than we do currently. We're working on it, but really happy and excited to share some of our work with you all, and always happy to chat after the break. Thank you.